Good afternoon, and thanks for joining us today. I'm Shannon Bernius. This is Healthline, where we like to focus on ways to live a healthier, happier, and pain-free life. And we're going to be taking your calls and answering your questions live in our studio today. And we'll be opening up the phone lines. And as a reminder, please make sure that you're in a quiet room when you call. Make sure your TV is turned all the way down. That makes us be able to hear you a little bit better. The number to call is 318-219-4569. Again, that's 318-219-4569. Well, today's topic, let's tackle that, is pelvic organ prolapse. And I'm joined by Dr. Karen Berken with Willis-Knighton Women's Health. Thank you so much for joining us.
You're welcome. Glad to be here.
We want to point out also, it's Women's Health Associates is the office that you work out of. And if you'd like to find out more information on today's topic, you can always go to wkwomenshealthassociates.com, and we're going to be talking to Dr. Berken a lot about pelvic organ prolapse. So let's talk about this. Pelvic organ prolapse. It's in the area of, let's just say it, the vagina, right?
Yes.
Okay.
So it's kind of a general term that's referring to any of the organs of the pelvis that can end up in an area where they're not supposed to be anatomically. So this could include the uterus or the cervix if someone still has those and has not had a hysterectomy. It could be the back of the vaginal area if they've had a hysterectomy. It could be the bladder, or it could be the posterior side, so more of the rectal area.
I almost wish we had a display, a model, right, so that we could tell people what it is we're talking about. So what happens? I mean, this is not normal for those organs to be in areas they're not supposed to. How does it happen?
So it's not normal, but it is surprisingly common. At some point in women's lives, about 10% of people will deal with this issue, and there are certain risk factors that can make it more common, but sometimes it's just genetics and you just don't really have any control over it. But there are certain increased risk factors which we can go over, but in general, it is where you have a weakness in the vaginal support structures. So there's a tough connective tissue layer called the fascia, and then there's also support structures higher up, different ligaments that support the uterus and the cervix, and some other muscles and structures in the area. And because all of these structures, being the bladder, the uterus, the cervix, and the rectum, are all within such close vicinity of one another, if there's a laxity or a tear or a weakness in any of these support structures over time, you can develop prolapse, and these organs can, due to gravity, fall in places that they're not supposed to be. And it can lead to issues as simple as just a little bit of minor discomfort or feeling or seeing a bulge vaginally that wasn't previously there. But then it can cause more important issues that need to be addressed more urgently, such as urinary leakage, urinary incontinence. Urinary retention is a big one as well. If someone can't empty their bladder, then that's actually a more urgent problem. And so I often see patients for these issues once they've been dealing with them for a long period of time.
Because people don't like to talk about this. I think about that commercial that's running on air right now with the actress Katherine Heigl. You've seen it probably, and it is the discomfort that people have talking about this. Women, I should say, women have talking about this. Men have trouble talking about it too, I should say. But what are the signs and symptoms that might signify that it's time to go see the doctor?
So you can have urinary leakage. So there's multiple different types of urinary leakage. I'll touch on just a couple of those, but you can have what's called stress incontinence, which is where there's some sort of a pressure or a stress. They call it a valsalva, where there's a push down and that causes leakage of urine. So that could be coughing, laughing, sneezing, jumping, going to work out, playing with your kids, whatever the activity is. You do this activity, there's that pressure or that push downward, and that causes urine to leak. There's also the opposite problem, which is urinary retention. If the prolapse is so significant that now everything is coming down and there's a kink in the urethra, then urine can't pass through the urethra appropriately, and so someone might actually have difficulty emptying their bladder. People often describe having to sit differently or maneuver differently while they're trying to use the restroom to try to allow urine to flow. There can be issues with pain, pressure, sexual issues as well, seeing or feeling a vaginal bulge that's quite uncomfortable if you're trying to just go about your daily business and walk around, and you constantly have this discomfort or this area of tissue that's in the way.
Does it also affect sex?
It can, absolutely.
Your enjoyment of that?
Yes.
Okay. So how necessary is it for it to be addressed, or is this something that's elective, that it's just if you decide you're uncomfortable enough that you should get it done?
Most of the time, at least early symptoms of prolapse, fixing those are more elective because it's not life-threatening by any means. It's not something similar to your appendix rupturing to where you have to have surgery right away, but it is over time likely to worsen. And so initially, if it's just a slight discomfort, maybe a little bit of leakage here or there, we try to stick with different methods that are non-surgical, conservative options, things like Kegel exercises or pelvic floor physical therapy. Believe it or not, there's physical therapists for the muscles of the pelvis too. Those muscles are muscles just like any other part of your body, and they can work wonders as far as trying to improve and reverse, or at least prevent future prolapse or incontinence.
Do those Kegels really work, though? I think that's a question a lot of women out there who may be watching may be wondering.
You have to be very consistent with them. You have to do them correctly. You have to be very consistent. There are Kegel exercises just kind of scratching the surface as far as what a true pelvic floor physical therapist can do. They have all sorts of TENS units and different weights and different methods to really objectively strengthen those muscles over time to where you can reverse or prevent prolapse. Now, if there's a significant prolapse and everything is almost inside out, and so you can, when you do an exam on someone that has significant prolapse, you can see their cervix, and you could essentially do a pap smear without any instrumentation because everything is past the vaginal opening. And if that's how significant the prolapse is, then you're kind of beyond what Kegel exercises and physical therapy can do at that point, and then there's some surgical options that you can potentially investigate.
And so are these diagnosed with a CT scan, or how are they diagnosed, or an x-ray?
Typically just a good old-fashioned exam. Getting an appointment with your gynecologist is step number one. What that would look like is scheduling a problem appointment. Oftentimes even I hear patients mention it during their annual exams because they're coming in for a pap smear. I'm doing an exam and I may note different degrees of prolapse that maybe even aren't significant enough for them to notice yet, but I may bring it up in the exam and point them in the direction of pelvic floor physical therapy or Kegel exercises so that maybe they can do something to where it won't get any worse. But they would come into the office. I would sit down with them, have a good conversation about their symptoms. Are they leaking urine? Are they having issues with bowel incontinence, having constipation issues, urinary retention? What pain symptoms are they having? And then oftentimes they'll describe it getting worse throughout the day. We live on a planet with gravity, and so sometimes gravity gets the best of us, and over years of dealing with different risk factors that may make prolapse more likely, mixed with the fact that there's gravity, things are just bound to start to fall. And so I'll
So it
ask,
might be different on the moon, is what you're saying.
yes.
It might be.
So I'll ask them questions about how things feel throughout the day, and then once I get a pretty good idea of what they're dealing with, then I'll do an exam. And the exam is very similar to a pap smear. We have a speculum, which is the ones we have are metal, but they're either metal or plastic, same thing that we use for a pap smear. And you do the exam just a little bit differently in the sense that you use the speculum as is to see if the area that's prolapsing is cervical or uterine, or is it, if they've had a hysterectomy, is it the back of the vaginal area, and is that what's coming down? Or is it more of a laxity or a weakness on the anterior or the top side of the vaginal area, which would be the bladder, then prolapsing down? Or is it a weakness on the posterior side, which would be the rectum prolapsing in? Think of almost like a hernia. You know, most people know what a hernia is. Hernia is a weakness in the abdominal wall, and bowel and things like that can prolapse through. And so if you have a hernia or a weakness in the same connective tissue layer of the vaginal area, then you can have bladder or bowel kind of prolapse through that defect. And
Very difficult conditions.
It is, and so you would use the speculum. We take the speculum apart to kind of isolate the anterior side and the posterior side, and I have the patient either stand or bear down, and I see which part is the part that's primarily prolapsing down.
Okay, we're going to talk about surgical options.
Yeah.
And I think a lot of people out there may be familiar with hearing about the mesh option. I mean, that's something that is very much discussed among women, it sounds like. But I want to make sure people have your information. So this is Dr. Karen Berken, and she works out of Women's Health Associates. And the email address, if you'd like to find out more information about her office, is wkwomenshealthassociates.com. And you can also reach out to her office by calling 318-212-7931. And if you'd like to ask a question today, and we'd certainly encourage it, give us a call. The number is 318-219-4569. And you are out of Bossier on Hospital Drive, right?
Yes, okay. Correct.
So if someone comes in and you've observed and diagnosed them with one of these conditions, what are the surgical options?
So surgical options are very dependent on what the prolapsing part happens to be. There are abdominal approaches to fixing these issues, and there are vaginal approaches. If the prolapse is very significant, then oftentimes the support structures that that person has and their native structures are not intact enough to provide enough support to where they have a low risk of recurrence. So in severe cases, you're often looking at meshes or different grafts, or doing a type of abdominal procedure to actually anchor what's prolapsing to a structure that's fixed, like a bone, for example.
And when we're talking prolapse, it essentially is kind of a code word for fallen, right?
Yes.
Falling.
Yes.
Okay, so when you hear the word prolapse, that's what we're referring to, a falling organ or a falling part of the body. Okay, so so surgical options. So that's what you talked about when you're talking about like anchoring potentially, or what about, you mentioned something having to deal with approaching it rectally.
So yes, so there are different types of procedures. So I'll take for example, so if the bladder is the problem, if there's a bladder prolapse, then typically you can go vaginally, and you try to open up that vaginal skin, which is called the vaginal mucosa, and you try to find the area underlying that thick connective tissue layer that has failed. Most commonly, it's been torn at some point, likely from a delivery or from carrying babies. There's a few other things that can make prolapse more likely, other than age and menopause and bearing children.
Childbirth.
It's definitely one of the biggest culprits, but you can, anyone that has a chronic reason for that Valsalva pressure or pushing down. So if you do heavy lifting for your job constantly, if you have COPD and are coughing all of the time, or have a condition where you deal with a chronic cough, certain weight lifters,
what about sitting a lot? Does that involve?
Sitting a lot is not necessarily a huge risk factor. It's more genetics, age, when you went through menopause, bearing children, and then those conditions that lead to just chronic pressure vaginally. And so for a bladder prolapse like we were talking about, you go in, you find that tough native connective tissue layer that has been torn, you repair that tear, and then you close the tissue over. That's called an anterior repair. That's a pretty simple procedure. Everything is done vaginally, and the recovery is pretty minimal. In addition to doing an anterior repair, sometimes if someone deals with urinary incontinence, which is very common, jumping, coughing, laughing, sneezing, and leaking urine, then as a secondary procedure at the time of that anterior repair, you can place what's called a mesh sling. There's many different ways to do this and many different types of mesh slings available and on the market today. But one in particular that I do, it's just a thin, it looks like a ribbon of very fine mesh. This is not the mesh of old days that we've seen all the lawsuits about. Now, of course, anytime there's something foreign being placed in the body, there's always a risk of infection. There's always a risk of erosion of that mesh. But these meshes are a lot gentler, made a lot different to significantly reduce the risk of those complications.
And there's also grafts. You were talking about that. Tell us about that.
Yeah, so you can for different procedures. Now, I don't do anything with grafts, but for significant prolapse, sometimes you can use different fascial grafts, which is just finding a connective tissue layer from some other part of the body and using that to repair the vaginal issue, or they have artificial or other animal-based grafts. But in general, all of these options are using some sort of strong, thin layer that is going to provide more support than that person's natural tissue. Maybe it's damaged beyond repair, or maybe everything has become just so lax over the years that there's just not going to be a good long-term result by using native tissue. And so you have to look elsewhere and look for some other stronger structure to provide that support.
Well, this is a fascinating topic for any women and for the men who love the women, especially during this Valentine's Day week. We want to encourage people to give a call, 219-4569, if you have questions. If this is a topic that maybe brings about a bit of embarrassment, this is a perfect opportunity to ask the doctor a question. You don't even have to come face to face. You can ask over the phone. So it's a great way that we are bringing this information to you. So we were talking about these surgeries. What you mentioned some of the recovery times. What are the risks and recovery times involved? And I mean, how long does it take until you start to feel yourself again?
So the actual surgery can either be done as an outpatient surgery, or in some cases, if it's a bigger surgery, typically spend one night in the hospital and then go home the next day. And because for a lot of these procedures, everything is done vaginally, really you resume your normal daily function very rapidly within a day or two.
There's not any pain, or
there's pain? Very minimal, just a little bit of discomfort. But the big restrictions that you really need to pay attention to are you don't want to overdo it. You don't want to do any heavy lifting, certainly no intercourse, and no really strenuous exercise that would apply that heavy pressure to the repair and potentially cause it to fail before it's fully healed.
Is bed rest recommended for this after this?
Typically not. Most medical procedures we've kind of steered a little bit away from bed rest. We've just found that deconditions patients and kind of gets them all out of whack. And so in general, if you can get back to your full normal function as soon as possible, that's the best. But with the caveat of no heavy lifting, no intercourse, and no strenuous exercise for about a full 6 weeks.
Okay. 6 weeks is what the recovery time is looking at. What about recurrence? Does recurrence happen?
It certainly can. It is more likely to happen the earlier someone has prolapse. So if someone has prolapse and they develop it in their 70s, let's say, then it took many years for that prolapse to happen. There are certain medical conditions that someone has an innate increased laxity in their connective tissue layers, and if someone has one of those, or if they've had traumatic deliveries or births and they develop that prolapse at a younger age, then they're certainly more likely for a recurrence. And that's why it's really important to see someone that does a full breadth of these surgical procedures and can truly decide which procedure is right for that person, because certainly not all prolapse is created equal. And if you have a repair for a significant prolapse that doesn't involve one of these artificial grafts or anchoring to a stronger support structure or using a piece of mesh, then you're at a high likelihood for it to recur at some point down the road.
And when we're talking about this, you mentioned births. Does it matter whether it was a vaginal or C-section delivery?
A little bit. Certainly bad vaginal lacerations and vaginal trauma plays a part in the increased likelihood of prolapse, but most of the studies show that just the act of just bearing children, just whether you have a C-section or a vaginal delivery, just the changes that the pelvis has to go through, and that those muscles and ligaments and tendons and everything have to stretch so much to accommodate that growing baby, that alone is the bigger risk factor, is just having babies, carrying babies, and the number of babies that someone has.
So if you're out there and you're a woman and you're considering having a baby, we certainly don't want this to be a consideration as to whether or not you're going to have a child, right? But there are maybe some things that you can avoid doing to avoid having this happen, right?
Yes. Well, and there are plenty of patients that I see that have never had a baby. They've never been pregnant in their lives, and they still end up with significant prolapse. So definitely don't change your childbearing desires, your
life's work,
based off of the risk of prolapse, because it can happen just purely because of lifestyle or genetics. And genetics, no one has any control over what their genes say is going to happen. So I certainly wouldn't make any major life plans, but you can more just be aware that it's a possibility, and staying on top of your Kegel exercises, and seeing a pelvic floor physical therapist, and identifying if you're noticing any of these symptoms, and certainly going to your routine annual checkups, because your OBGYN will note if everything's in the right place or not. And so there are plenty of patients that come in to see me for just a routine checkup, routine pap smear, and then I'll see something, I'll start asking, do you have issues when you are working out and you start doing jumping jacks, and you sneeze, or you cough? Do you leaks from time to time? And 9 times out of 10 they say yes. It's a very, very common issue. And so,
but are all of them prolapse, or it's a degree?
It's a degree. Some of it's prolapse, some of it is just laxity of the muscles, and so with those activities and that increased pressure, your bladder can move just enough, or your urethra can move just enough to where a little bit of urine can make it out, and it's very bothersome. It affects people's quality of life. If you are an avid runner and you can't run unless your bladder is completely empty, that's a big deal. And I also see a lot of women, older women, that really just want to play with their grandkids and go out and garden, and they can't do that because their prolapse is so significant. There's another surgical procedure that I do. It's called a colpocliesis, and it's one that you can really only do if the prolapse is so significant that everything is outside. So bladder, cervix, uterus, or if they don't have a cervix or a uterus, the back vaginally, everything is prolapsed so far past the opening of the vagina that basically everything's inside out.
Still within the body, let's be honest, right? I just want people, we're not talking about organs hanging out of the body, or are we?
A little bit, yeah.
A little bit,
yeah,
okay.
A little bit. Sometimes prolapse can be if someone stands up and they're having a prolapse, you can see the bladder and the uterus and the cervix prolapsing past the vaginal opening. A good a good distance. And you could
So
imagine
that's something that instead of being embarrassed about, it's something that you can go see a doctor like Dr. Berken about.
Yeah, and you could imagine how that would be just very difficult to
Yes.
to go about your daily life if you were experiencing that. And so this colpochlesis procedure is where you essentially put everything back in its normal orientation, just one step at a time, and then you use some of the more external vaginal structures to essentially kind of close that opening. You can still have bowel movements, you can still empty your bladder just fine, but basically that vaginal opening is closed off. And that's a procedure that obviously is a little bit more drastic. It's reserved more for older women that have very significant prolapse and a high risk of recurrence unless you do that. But everything's done vaginally. You're avoiding a major abdominal surgery for those patients. You're significantly changing their quality of life. And most of those patients, or one of the conversations I have with those patients beforehand is they have to be okay with just not being able to be sexually active after the procedure. But as long as they're okay with that, then it's a really, really good procedure for the right patient.
And something else I was wondering about, often when women are going through menopause, they're told to try estrogen. Does estrogen have any effect on this? Thinning vaginal walls or anything like that?
It certainly does. Vaginal estrogen is depleted as soon as someone goes through menopause, whether that's natural menopause or surgical menopause. But as soon as that estrogen is gone, then the vaginal tissue changes. It goes from more of a brighter pink color, very elastic, very moisturized, to thin, sometimes paper thin, easily torn, not very elastic, and then the support structures do weaken as well. And so there are different estrogen therapies, topical estrogen creams and vaginal inserts that can be used to replenish that vaginal estrogen which has been lost. And therefore,
does it lead to prolapse, or is it sometimes hand in hand, or is it not the same thing?
It's certainly, when someone hits menopause, prolapse becomes much more common. And so the changes to that vaginal tissue and those vaginal support structures from menopause and from a lack of estrogen definitely contribute to increased likelihood of prolapse. Now, if someone's undergoing a procedure, a surgical procedure, then oftentimes I will prescribe some vaginal estrogen before doing the procedure because I want to get that tissue as healthy as possible before doing surgery because I want it to heal very well. And so I'll do a short course of some estrogen therapy even before surgery.
I see.
But once someone hits menopause, if they're having any vaginal symptoms at all, it's very common, and I would recommend doing some type of a vaginal estrogen treatment because it does not work quickly. It works over a long period of time, and you have to be consistent with it.
Final question here, Dr. Berken, because we've had this conversation for about a half an hour, and so far nobody's called in. I'm trying not to take it personally, but when we're having this conversation, this is a topic that sometimes can elude a little bit of, I guess, discomfort, embarrassment talking about it. What do you tell your patients to put them at ease?
So I'm not surprised that no one's necessarily called in because it is a little bit of a taboo topic. Menopause and pelvic organ prolapse and lots of female issues are just not talked about to me. I don't think they're talked about nearly enough. I talk about them every single day, so I guarantee that anybody listening, anything that they say, anything that they tell me, anything that they show me, it is not the first time I've seen it.
Or heard it.
Or heard it. And when they leave the appointment, they always express kind of just a sense of comfort in knowing that they're not the only one that's dealing with this, that there's actually millions and millions of people that are dealing with this, and there's ways to improve it, ways to fix it.
Solutions to the problem.
Just to know that you're not alone in this problem and to talk about it openly, I think hopefully will help people come forward if they're having these issues.
Well, we certainly appreciate you talking to us and to our audience and offering this information about vaginal health and pelvic organ prolapse. And again, if you'd like to contact Dr. Berken outside of this conversation, you can contact her at 318-212-7931, set up an appointment, or go to their website, wkwomenshealthassociates.com. It's been great, Dr. Berken. Thank you.
Yeah, absolutely. It was great to have here.
Have a great day, everyone.